Thank you and good morning. Thank you to Dr. Borwong and the organizing committee for the privilege of speaking on the different guidelines on AAA management and what is ideal for Asian countries. So there's a perception that guidelines developed in North America and Europe may not be directly applicable to Asian populations. Those differences may be changing because of gradual change in diet and lifestyle in Asia. So I'm going to just briefly review 3 guidelines on the management of AAA that have come out in the last year and extract salient points to see if we can apply it to treating our patients. The first is from the Society of Vascular Surgery guidelines on the management of AAA, for which Anthony Lee is one of the contributing authors. The second is the more controversial UK NICE guidelines on abdominal aneurysm management, which has generated a lot of debate. And lastly, the ESVS clinical practice guidelines for abdominal aortic aneurysms, for which Germano is also a contributing editor. So the question to answer in this context is, for Asian patients, what size do we intervene at, and do we offer EVA or open surgery? So starting with the European guidelines, this is an 80-page document. I've extracted the relevant bits to discuss for this talk. And this is just to start with the definition of a AAA. So in European men, this is defined as an abdominal aortic diameter of 3 centimeters or more in the AP or transverse diameter. And they make a point that a lower threshold may be more appropriate in men in some Asian populations. They also state that you can also use the suprarenal normal aorta as your reference point, and anything more than 50% than that qualifies an aneurysm. So coming to their recommendations, in men, the threshold for considering elective repair would be to 5.5 centimeters, and in women it would be 5 centimeters. So the class of evidence is level 1 with men, class A recommendation. And so it may be reasonable to extrapolate this to the Asian patient with a slightly smaller stature, where the intervention threshold will be between 5 to 5.5 centimeters. And then whether you offer EVA or open surgery repair, their recommendation is that in patients with suitable anatomy and a reasonable life expectancy defined as above 10 years, then endovascular repair would be appropriate. However, if you have a patient who you expect to live much longer, between 10 to 15 years, this is long life expectancy, then open abdominal aortic repair would be preferable. And lastly, I think this is quite relevant. If you have a patient with limited life expectancy, that is 2 to 3 years, then neither open or endovascular repair would be recommended. So moving on to the SVS guidelines for AAA, just extracting some relevant bits of it. So they've shown that smoking is a positive predictor for aneurysm growth, whereas diabetes is not. We have more diabetic patients in Asia than smokers, I think. This is a meta-regression chart showing aneurysm growth against, aneurysm size against growth rate. So in other words, the larger the aneurysm is, the faster it grows. And this is useful when you see a patient for the first time to plot them, their current state and then try and predict at what stage they will reach that 5.5 threshold. This is shown in this graph. So the closer you are to 5 centimeters, the quicker you will grow to 5.5 threshold. And this allows you to then do cardiac risk factor assessment and just talk to them about whether endovascular or open repair would be more appropriate. This is an interesting assessment tool for operative risk. This is based on the VQI assessment, and it looks at the treatment modality, whether it's EVA, open, infrarenal or suprarenal repair, aneurysm size, age, gender, comorbidities, and creatinine levels. And then you can risk stratify these patients into low risk group, medium risk, and high risk, and ultimately then decide whether you want to do open repair or endovascular repair. So coming to the more controversial guideline, this is the NICE draft guidelines. Basically, they do not recommend EVA in the setting of an unruptured aneurysm